right. So again, a reminder, if you all haven't subscribed to our YouTube channel, please do. I can share the link for you guys in the Zoom meeting, but you can get notified when we do go on these live videos, or also find a bunch of the previous ones. The meetings that we have in this session are usually recorded there, including the great series that Natan just finished on spatial analysis, which was really nice. And this one will be a good one too, no doubt. So today we have Eduardo with us, who comes from Manaus, where he heads up emergency pre-hospital services there, which I'm sure you'll tell us a little bit about. And he's going to talk to us about some really cool work around COVID and mental health emergencies, if I'm not mistaken. And I'll hand it over to Eduardo to take it over.
Thanks, Ashley, for the introduction. Morning, everyone. Thanks for joining. Please just confirm if you can see my screen.
We're seeing the on this Zoom, we're seeing the view of two, like the presenter mode.
Yeah.
That's perfect.
Okay.
All
right, everyone. So thanks again for joining us this morning. Thank you for the introduction, Ashley. So I'm Eduardo, and we'll be talking today about psychiatric emergency management and health system resilience, which is part of my dissertation. And that's a 10-year interrupted time series analysis of the COVID-19 pandemic. I have no computer interests. AI was not used in this presentation. However, I was funded by CAPS, which is one of our national institutions for funding PhD students to have experience abroad. So today we're talking about Brazil and its universal health system, our Sistema Único de Saúde, which has different actions in healthcare service, starting from primary healthcare and going through all the way working with health promotion, prevention, early diagnosis, treatment and recovery throughout Brazil for everyone living there without a cost. And although primary care is its main priority, we have emergency care as well. Yes, we have emergency care as well. So as part of it, we have health promotion and prevention, which is often overlooked, but it is also considered part of our emergency care within SUS. And some unusual, but also important, such as primary health care, both as part of current overseeing of patients and avoiding that they decompensate and have to require emergency care services. The same as for home care, which hopefully is integrated with hospitals, and as soon as patients are discharged, they are automatically seen by a team, and this could provide efficient services and avoid rehospitalization. We have stabilization rooms, which are not very common, but they happen specifically in more distant regions where healthcare access is less complex. So we have small places with stabilization rooms so that we can make patients ready for transport for bigger centers. And when we talk about bigger centers, we have both emergency hospitals, traditional ones, and clinics, which are less complex institutions that also see emergency patients. And within emergency response, we have SUS National Health Force, which is a very important part of our emergency care system that usually responds to great natural and catastrophes across the country. And of course, today we're talking about our SAMU, which is has a very nice explanation in our law, which states that mobile care component of the emergency care network, and its main aim is to reach the victim quickly after a health incident has occurred. And it doesn't matter what, if it's something like clinical, surgical, traumatic, obstetric, pediatric, psychiatric, among others, that may eventually lead to suffering, long-term effects, or even death. And this is done by dispatching vehicles staffed by trained teams and accessed by our national number, which is 192, equivalent to the American 911. And this is activated by an emergency coordination center or dispatch center, which is shown right here. Okay, that would be like the core of the emergency care system within SAMU. And if anything happens, whether on the street, like a motor vehicle collision, or someone that needs assistance from home, or even inside a basic health unit, or
Mhm.
emergency clinics, or big hospitals, it doesn't matter. You just call 192, and you have a special team there to assess this call, to triage it according to its complexity and need of uh, emergency assistance. And whenever necessary, we have special vehicles that are dispatched for this. And depending where you are, you have different distributions of those. This is just to depict the city of Manaus and our automatic external defibrillators and motorcycles and mobile ICUs. But we also have for our more distant and geographic isolated populations, other means of transport, especially to use in our river pathways, as well as helicopters, so that we can provide efficient care. And one of the main roles of emergency medical services and emergency care as a whole is to work with response, of course, but also to think of it in a preventive way and to foster preparedness so that we can provide better response and always think about recovery as an opportunity to learn, rebuild, and offer better services, especially when we talk about disasters like this great one we had, in which WHO offered us some recommendations about how to deal with the longstanding aspects of those. And that involves, of course, surveillance, access to countermeasures, scalable care, community protection, and emergency coordination, so that in case of new surges or with this longstanding demand, the emergency medical services are ready to respond to those. And one of those important aspects is mental health. So WHO stated that after COVID-19 pandemic, we saw a trigger of approximately 25% increase in the prevalence of anxiety and depression worldwide, with a special concern about suicide, considering its strong link with economic hardship and other health measures which were part of the pandemic, such as social isolation and losses, whether direct or indirect, as well as a widened mental health treatment gap in most places, especially in Brazil. Access to mental health care is quite complex, and after the pandemic, this is probably a new challenge to be faced throughout the next years. And when you talk about Manaus, it's actually a bit sad to remember that it was news worldwide about terrible things that happened there involving logistics and problems with basic needs for healthcare, like oxygen, especially when it comes to more vulnerable people, and coming to a point where both health and logistic crisis converge to terrible scenarios with mass graves. So we started this at the beginning for the first 6 months, and it called us to the attention that our SAMU in Manaus, the first 6 months of the pandemics, had a great disruption of the calls themselves, the way they worked, the number of calls, and how they were associated with the number of deaths, both by respiratory conditions as COVID, as well as when you look at our official information systems, such as our notifications, which are compulsory in hospital settings, they were very closely associated with the change in the number of calls within our SAMU in the first 6 months of the pandemics, which makes us think that probably this is something which needs to be explored, considering that most pandemic mental health studies come from high-income countries. Few of them cover more than the first years of the pandemics. And to the best of our knowledge, none of them are in the Brazilian Amazon. And considering that Manaus was one of the world's most severe COVID experiences, we thought that SAMU might be an early psychiatric emergency, an important contact point, probably working as a proxy as a population level signal. It's important to say that this dissertation is a broader project that involves other variables such as climate and social determinants of health, and this is being granted by our state's financing institution. And the data we'll be presenting here today is part of this broader work. And our main question today is, did the COVID-19 pandemic alter the temporal trend of monthly SAMU psychiatric emergency calls? And if so, were these changes characterized by immediate shifts or progressive ones, or maybe both? Our hypothesis then were that at first, the beginning of the pandemic, no abrupt level change was seen, but as time went by, probably we could see a slow and continuous increase throughout the pandemic. And at the end of this, we hypothesized that no recovery to baseline, to pre-pandemic baseline would occur. So our primary objective was to evaluate the temporal trends of emergency medical service, SAMU psychiatric emergency calls in Manaus between 2015 and 2024, considering the COVID-19 pandemic as a structural determinant. And as a secondary objective to describe social, demographic, and clinical profile of patients who received care this period, and to calculate monthly incidence rates, adjusting for population growth. So when we talk about design, we work with an observational, retrospective, quasi-experimental study using the pandemic as a natural experiment. So this interrupted time series had two main intervention points, which were used as our worldly known WHO declarations to make it more worldwide available, even though that this could not reflect actually what was happening in Brazil, but just as landmarks that we would have. And thus it was divided in three analytical segments: the pre-pandemic one, the pandemic, and the post-pandemic. Our pipeline included first large filter of over 900,000 calls throughout the 10 years. And these calls were de-identified. We had duplicates excluded, time conversion to work with the month granularity, corrected age outliers. Our calls, which have the reasons registered, were divided in two different categories. One more clinical, being diagnostic statistic manual, more clinician-based a more clinician-based stratification, and one more straightforward based on severity, which we decided for three: life-threatening, severe episodes, and minor, moderate. Our model outcome first tried to address the fact that we're working with a decade of data. So we have population growth, which had to be considered. It was about 10% in Manaus, according to our Brazilian census year estimates. So growth alone could mimic a trend. And we had also an issue with our data for 3 consecutive months. And we decided to use this functional forecast so that we could avoid this 3-month gap in our interrupted time series. And our final outcome then was monthly incidence rate per 100,000 people. And this is what we're going to be working next. Our analytical plan involved first an observation sorry, working with our observation, checking its variance. So we had evidence of over dispersion, which led us to think about testing two different models mainly, even though we knew that it was probably favoring negative binomial, which the square, which the test, our test eventually confirmed to us, as we can see. And for the prediction model, we chose 5 parameters for the model, being number 1, the time, which is the number of months before our first transition into the pandemic period. And then number 2 is this actual pandemic transition, so that we check if for this we have any kind of sudden change in the trend of calls. And number 3 is the second period of time between transitions 1 and 2, which is the pandemic itself. And number 4, the second transition from the pandemic to the post-pandemic phase. And finally, we had this counterfactual scenario, which personally I like it very much. It seems to me that we're playing Back to the Future. So we just tell the model that that didn't happen, go back in time, and we say, okay, so COVID never happened. Consequently, there was no pandemic or post-pandemic, and then the same model runs those data to check what would have happened in case the pandemic had not occurred. So for table 1, we have an analysis comparing pre-pandemic and pandemic. First, about sex, we had a larger difference in the pre-pandemic phase if we compare to the post one. According to the age group, we saw that young adults and adults, they were still predominant in our sample. However, we feel that there is a slight trend towards a greater number of young adults instead of older adults. When we see call origin, we see that most of calls in the pre-pandemic periods came from home, and this trend remained the same, although we had a higher proportion of out-of-home calls, which means that these people in the post-pandemic phases had some problem with psychiatric emergency in public spaces or health facilities. For the first stratification into 3 different severity categories, we have the life-threatening, severe, moderate, minor, and we can see especially an increase in severe episodes and a decrease in moderate minor episodes. When this category was seen according to the diagnostic statistic manual categories, we saw important increases in anxiety, self-injury, suicidal behavior, and psychotic episodes, which had a very interesting increase, a 5-fold increase in the number of emergency psychiatric calls. And about destination, we also saw an important change from psychiatric hospitals, which are units who dedicate their care to, let's say, specifically mental health related. If we compare emergency clinics and hospitals that also take these patients initially, but they usually have something else associated, like some change in their vital signs or maybe substance abuse. And this is another setting for other causes of changes in mental emergencies. This heat map shows us the 10 years, the x-axis, and the y-axis 12 months. And we have the COVID-19 pandemic there. And in the first 2 years, it's probably possible to see that the incidence rate was a bit lighter, which means that the incidence was lower, and it got darker, so towards the 16% there, and we can see the legend for the next 3 years throughout the pandemic. And when we analyze the months, it's probably possible to see that the first semester is usually associated with higher numbers, higher calls, if you compare it to the second semester throughout the period. This first figure shows us in blue the observed rates throughout 10 years. Okay, so you have this a lot of noise, and trying to make it more smooth, you have this loss trend curve with a 30% span. And this gives us initially just a visual so that maybe we can have some inferences, like probably seeing a decrease before the pandemic, and then some ratification and an increase afterwards, especially after 2022. Now the model itself shows us when it's fitted, which is the red line, that we have in the pandemic period this reversal trend. So it was actually getting lower. We had this reduction, and it started reverting the curve and keeping it after the pandemic, as we can see with the parameters. So when we look at the baseline trend, our incidence rate ratio as 0.997 tells us, in other words, that throughout this period we had a 0.3% monthly decrease in average, which shows us this decrease trends before the pandemic. The second one, which is level change, when we ask, was there a sudden change when pandemic starts, our p-value was not significant, which confirms our first hypothesis of not an abrupt change at the beginning of the pandemic. However, we see a slow change with this IRR 1.005, which in other words means that throughout the slope, throughout the pandemic periods, this slope was consistent and increasing about 0.5% monthly, and this was statistically significant. The other two levels assessed by the model, which were level change at the pandemic, which is transition from pandemic to post-pandemic, and slope change post-pandemic, which is behavior of calls after pandemic ended, there was no statistically significant result, showing that this trend found at the slope in the beginning of the pandemic tended to continue even after the pandemic finished. When we decompose these data with trend, seasonal, and remainder analysis, we can clearly see the trends that it was actually reducing before the pandemic, and then it started increasing throughout the next years. And the seasonal shows us that there is actually a year-to-year pattern of higher cases in the beginning with lower incidence rates in the end. And this was actually tested maybe for another model which included these parameters, but the results were in favor of keeping a simpler model in the parsimony strategy, understanding that it was more complex and that it would not add important and different results, including season as parameters for the model. And about the remainder, we also had some tests for autocorrelation, partial autocorrelation, and what we can see visually was confirmed by test box field, which shows us that this distribution of residuals, they were not dependent So standard errors are reliable, and this helps us confirm the conclusions from the model. Sorry. This last figure shows us that when we add the counterfactual model, as we discussed before, which is adding a scenario in which the pandemic had not occurred, which means that this dashed green line represents a continuity of that decreasing trend that was happening before the pandemic started. It helps us detect visually and confirm with the numbers an excess of calls starting right from the pandemic period. So that was a 9% excess of calls if you compare to observed data. And when we look at post-pandemic, it was an even larger effect, reaching 35% excess calls if you compare the attributable effect of the pandemic versus the counterfactual model. We also tried a more simpler two-segment only. So instead of using two intervention points for beginning and the end of the pandemic, we kept only the beginning. And this confirms that we also had that same in the end, 17.5% combined excess of calls, which helps us strengthen that our model was robust and that our trends persisted despite the use of a second intervention point. So it's possible to see again in this two-segment model that there was a baseline trend of decline, which was reversed when we use the structure determinant of the pandemic as a division for this new period called the COVID-19 pandemic. And we see this slope in increase the number of EMS calls. And then we compare here the 3 and 2 segments, which confirms in numbers what we were discussing. So there's a consistent increase this in the incidence rate, whether the model uses 3 or 2 phases, but we had statistically significant results favoring an increase of 0.5 to 0.7% month after pandemic started. This allows us to confirm our first hypothesis that there was no sudden level of change at pandemic onset. However, with time, it was possible to see that this increase was progressive and it kept going even after the pandemic and with no recovery to our trend of calls in the pre-pandemic baseline. So our key takeaways are that considering that sudden level changes for mental health were not seen in our sample, when you think about health system resilience, probably this is not a best early warning sign because we cannot use it as a marker for short-term actions for response. However, this characteristic of a sustained slope is important for middle and long-term planning, and especially for the recovery phase, where we understand that this excess number of calls is probably impacting not only emergency healthcare, but also the health system as a whole. And the fact that demand kept climbing after the end of the pandemic is important for us so that we make sure that the end of something is not actually an end, and that some things might keep going in the model of the cumulative effect. So even though the viral circulation and vaccines were very efficient and prevented many deaths, this delayed effect of the presence of the virus and all of the losses of every type, direct or indirect, they have long-lasting effects, and we might see this for the first few years or not. Time is going to tell us, but that these data could be an important marker for us. And considering that the post-pandemic burden exceeded the pandemic burden, it's still not possible with this sample to state this, but it's possible that this could be still increasing or happen to increase even more if our variables which are used and the way we're dealing with this are not changed. So this is something that, in terms of public health, is something that has to be taken very seriously. About emergency medical services, it's important that we see, of course, its important role for assistance, thinking about population level and its use for the emergency system as a whole, but also this often overlooked characteristic, which is very powerful data. So we have people in a situation requiring emergency psychiatric services. We're not talking here about ambulatory, it's not minor cases of depression or anxiety, but we're talking about major behavior disruptions and talking about suicidal behavior, we're talking about aggression. So when you look at those data coming from EMS, this is maybe something we should be putting our attention into. And also this design we used, it might be used for monitoring health system resilience in the long run. And especially considering that in Brazil, we could say we have very robust information systems. However, it seems to me that we are underestimating the data we have here when we talk about public health, because understanding the emergency care better, looking at a service which covers about 90% of the Brazilian population, so that is 200 million people, and we understand their urgent needs. We see that which is more prominent for a health service, which is pressing health system and testing its resilience, is probably some data which we should be looking at further and using and testing different model designs to make better policy decisions. So I would like to acknowledge our funding institution and our university and our Medicine Tropical Foundation, and back in Manaus, professionally speaking, the health department and SAMU Manaus, and here specifically all the folks at Duke for having me here and giving me this great opportunity to be discussing this. And especially the people involved that make this all possible, starting from now, the people from work, our research teams, our friends, my new friends here, especially those who made this moment real. So for the opportunity given for our day-to-day routine here, with a lot of work, but also a lot of fun. So thank you very much for the great opportunity. Without you, none of this would have happened. And I'm now open to questions, comments, and insights. Thank you for your attention.
Wonderful.
Nice.
Yeah. Join us in thanking Eduardo. This was wonderful. I really love your point about emergency medical services being involved in preparedness, planning, and prevention, because it's something that can be lost sometimes. With a background in public health and health behavior and prevention, I never really thought I would be in emergency medicine, because it feels so far from that prevention. It's the last point we want to be, but as you reminded us, actually, they're quite important place to work on preparedness and planning and prevention. So thanks so much. We'll open up for questions or comments for Eduardo. Folks online, feel free to raise your hand or write in the chat. Baraka has a question in the chat. saying thank you for the good presentation. I would like to ask for clarification regarding the age categorization used in your study. What was the rationale for defining adolescents as 11 to 17 years instead of using the WHO standard of 10 to 19?
Okay, thanks, Baraka. This is a great question. When we thought about the stratification from younger children to adolescents, we tried to think of a bit of physiopathology, thinking about mental health, in which we have some conditions which start increasing in this adolescence phase. So we find something different there, but I completely understand this is reasonable to think of using the WHO cutoff point and making it only into one category. Thank you.
Yeah, I have several questions, but I want to make sure folks have time to.
Some more congratulations in the chat. Anyone online have any questions or comments? Feel free to share.
I can ask a question before João goes, because I've seen you present this before, Eduardo, but overall great presentation, great work. I wonder if you can speak on the service itself. So how current, or how timely the curves for COVID and the curves for the actual psychiatry cases align. Did you see the pandemic start and then there was a delay? You actually noticed that in the service? Because your data is showing us that in fact the psychiatry calls took a while. It wasn't like a bump after the pandemic. But in terms of the actual, shortness of breath, viral infection, pneumonia cases that were reported, was that did that came before the psychiatry cases? Tell us.
Yeah, sure. In this preliminary analysis that we had for the first month, so here we're seeing a larger framework, right? So we're looking at 10 years. And specifically to the mental health cases. But when we look at the service as a whole, the proportion of mental health cases actually decreased because we had specifically the cases for respiratory emergencies increased so much. But this was a short-term adaptation for the service. So in like a few months, maybe 4, 5, or 6, I have these data, but not in my mind, all of them, of course. We kind of saw things coming back to normal. And in a short-term fashion, it was probably not easy to capture this change in mental health calls. But throughout the years, maybe that changed. I'm not sure because I haven't seen all the data for the 10 years for all our reasons for calling, but for mental health, this really called my attention.
Okay.
So I think this is beautiful, man. Beautifully done. The storytelling is great. The graphs are beautiful, just very publication ready. So congratulations. I also like that you are maturing a analytical framework that João and I have been talking for a while. When you think about this work of understanding how much climate is impacting, I think you're helping to mature what this methodologies and bring this idea of excess deaths to understand association with different extreme weather events, which is a big area of work that we are doing right now. So I really like to see that, and I'm very excited to see what those next stages of your work are going to be. So great job on doing that. Some things that I think you probably thought about, but I'm curious. One is, how did the coding happen? So when you're defining these psychiatric cases, how did that coding happen? How did you define those psychiatric cases?
I'm sorry I couldn't show you all our original categories because I thought it was too time consuming and maybe it wouldn't make sense for this presentation here. But we have an information system which is used in many of SAMU systems throughout Brazil, and we have predefined categories. So for example, for the first severity category we put there, which was
Can you write those slides up?
Sure.
Maybe you can share again.
Digest this a little bit.
All right.
Now that you're plugged in, you can also put your camera on Zoom to the webcam.
Usually the tablet cannot take the microphone and the camera at the same time. No, that usually happened with me last time as well, with the
Oh.
tablet.
You think I should try?
You can
You can
try.
try.
Yeah.
At least it will show. Oh, no, it is showing. Yeah.
But if
It's
the
showing
It's
capturing.
blurry.
Which microphone is it capturing from?
Yeah, it's all
I think it's-
working. The microphone and the camera is working.
Well, the microphone could still be the tablet one.
But okay.
Did
Can
you hear
us
it?
now?
Can you hear us
Let me
now?
try that.
The transcript
Can you
is
hear us
coming through,
now?
so something can be heard.
I'm just trying. I was testing. I muted it here. Just
Okay,
testing.
Oh.
okay.
That's what I was trying to say.
I'm going this way, okay, so I think it was working.
That's good. It's good to know. Yeah.
Okay.
All right. So yeah, I
All right.
was asking. Yeah, because
Let's talk about the categories.
yeah.
Oh, will you share the screen to the Zoom?
Oh, I'm sorry.
That's okay, so everyone can see. So on the bottom, oh, you're in French, huh?
Sorry.
Oh my God, I want
Pardon.
Pardon.
For the categories, we have redefined the system, not only for mental health, okay? So in general, there are larger groups like surgical, clinical, mental health, OBGYN, pediatrics. And inside these larger categories, for example, for mental health, you have sub-classifications such as schizophrenia,
Okay.
bipolar disorder, depression. And what was the word for coding? I picked two different categories. I had a talk with Rovitor beforehand. Because maybe that could be used for different journals, for example. So for more clinician
Yeah.
side of the force, would like to see maybe more formal diagnosis.
Yeah.
And this, I thought it was more straightforward and it deals a bit more with what we work when we think about emergency. So something which is life-threatening is very different for something which is a moderate minor episode.
That's what I'm curious. Who
Are they-
defines life-threatening? You defined it.
I did.
So you took the disease categories and then you applied this severity definition.
Yes.
So then you have a key that says if it's psychotic, then
Perfect.
it's severe. If it's suicidal, it's life-threatening.
Yeah. something
Okay.
like that.
So I think that's something that we probably want to make very clear in the paper, how you define them. But that's fine. I was curious. The other curiosity I have is in the definition of, so who tags this to be bipolar? Who tags it to be psychotic? Is that something that the SAMU professionals are crafting that categorization?
Yeah, this is the information we obtained from the patient, or in this case, probably something which is calling for the patient. So
Okay.
there's a mother, there's a father,
Go
there's a
to
son.
the next slide, please.
Okay.
But is it coded at the time of the at the time of the
This is what
call?
I'm trying to say. The DSM category, who is matching the DSM category? Is that the call taker?
Now, the stratification was done in the moment of coding,
Okay.
but we have many more other categories.
Sure.
Which I had the work to fit them into the most.
Okay.
Can you share an example, like for instance, for anxiety? for
Yeah,
instance?
sure. For example, anxiety, I recall now we have like panic disorder, we have like generalized anxiety disorder, we have
Okay.
like palpitations.
Yeah, I hear what you're saying. I'm just trying to think that this increase in psychotic disorders, I'm curious to see how much of that is coding versus
Measurement.
actual psychotic disorders, because it's a very high proportion of calls due to psychotic disorders. I'm curious what the literature says about it. Because and then psychotic also could mean many different things. Like you could be going through a psychotic outbreak, but not necessarily have a psychotic disorder.
Right.
Yeah, sure.
So I think that there's something around just defining what these things mean, that could tell the story, right? I think it's very interesting that you're getting a higher proportion of calls due to potential mental outbreaks that might not necessarily have everybody be schizophrenic or have that level of. So I was just curious about that. I'm also curious how much suicidal ends up being tagged as psychotic because of stigma.
Okay, I see. Now, that's a great question.
Yeah,
If we have, this is SAMU, okay, we're not talking about seeing patient in a clinic.
exactly. Yeah,
We're talking about an emergency.
Yeah.
So if we have patient with a psychotic disorder, so has a diagnosis of schizophrenia, say,
right.
but in that moment, he's calling because he's trying to put his mom.
Yeah,
The ambulance is gonna go to code red and it's gonna be murder attempt, something like that.
okay.
So that for this system doesn't go into psychotic, it goes into
Violence.
violence prevention.
Right.
Okay, so now for psychotic itself, we have categories there which are diagnosis. So for example, bipolar or schizophrenia. And we also have the clinical component. So
Yeah,
if someone says, because he's hearing voices
Yeah.
inside his
Yeah.
head,
Yeah.
so that goes even without a diagnosis, that still fits into psychotic.
okay. No, that makes sense. I think unpacking that would be important because what I'm getting at is that we've done some work before on trying to create classifications for the chief complaints of calls against these definitions. And what we've learned, at least working through the data, is that it's very hard to discern some things based on just what the person is saying. So I was just curious how consistent those classifications are, because I think that there's several reasons why that's interesting, at least to me. Okay. The other piece on this slide that very interested me a lot was that there's a reduction in substance related, which I think that's a very interesting result on its own that I would like to unpack at some point. So I'm one of the suggestions I was going to make is you make this analysis overall for all mental health calls. I was curious if you could redo the same analysis, but now picking up some of these categories to see what is that behavior over time. I think there's a lot of discussion of people saying that post-pandemic start, there was an increase in substance use and alcohol use, and then there was a decrease. Some people are saying that the alcohol use increased, but it was not binge, it was not causing calls. So there's something to unpack that is interesting there, which I would be curious to see how those look like as well. Yeah. But yeah, that looks good to me. The only other comment that I have is on the figure. Go to the next slide.
Heat map?
Yeah, I think the heat map threw me off a little bit. I don't like it very much.
It's hard to find a.
Yeah, I think this is like perfectly an overlapped curve, so you can show how all the curves overlap. I understand that probably the curves are not very good because you have a very flat curve. Your variation is small, so you're probably not going to see all the variance you're trying to show with the heat map. The argument you're trying to make makes sense to me. I just don't think this is selling it. Yeah.
Okay.
Yeah, probably that the composition would show this better. Like
Yeah.
for the first half of the year, you have the seasonal trend versus the actual trend would be enough.
Yeah,
Sure.
And I always like to see the raw curve of things. So I think it would be important to see the raw curve of time overlapped, and I think that helps to see the seasonality and those things. So it helps to see the raw data. And then the next slide, I think this go 2 slides forward. I think this is where you're trying. Yeah.
The model.
Yeah, for this slide, I think this slide looks great. What I would suggest for the paper is to, I think there's one slide where you have this figure, and then you have the counterfactual,
The green.
and then you have the table with the coefficients. Yeah, I think I would probably do something similar with that other figure here. You bring the coefficients with, and then you flag in the figure where the time points are. I think you're making a lot of sequential analysis that it's hard to follow sometimes just looking at the table with the coefficients. So the same way you have this shaded area for COVID pandemic, if you could have just a marking saying this is where I'm analyzing an interruption number one, or have the code you're using, I think that's kind of important, because what I see from your data is that after this COVID period, the data kind of flattens out a lot. Right, that period from 23 to 25, it seems flattened. So I'm curious to see if that's going to continue to do a shape to go back to the declining trend, or I don't know. It's just interesting that that period of time has a flattened curve. But I think on your results, it does show that there was an improvement in a change in that space, or it was just a change towards the beginning of the pandemic.
So this one,
Yeah. Okay, no, that was just this low change. Okay. Okay. Yeah, so I think I would put this time markers into that figure, so it's
Use
kind
the
of
same
easier to
nomenclature,
see, yeah,
Something like that.
what you're trying to say there. And
One thing that I thought based on the table is that you're showing us 2 breakpoints. So we actually have 3 time points. So pre, during, and post.
yeah,
And in the tables, we only see pre and post for the number of cases. So
yeah,
you are clumping up.
the table 1 and 2.
Yeah, so I wonder if you would transform that into 3 breakpoints.
I see.
But I don't know, because I understand that the thought of describing the 2 periods before as WHO does. I don't know, and then following up with the actual analysis and proposing the 3 things.
It didn't break me off at that point. I think the tables are fine in showing, like, I'm trying to see before and after, but in the analysis, what you're saying is, I want to see what happened in the pandemic time and then after the pandemic time. I think that makes sense.
One thing that I would really love to see is a control series. So think about, so you are in the most acute system, the most real-time data, which is the EMS. You are getting the patients as they are having the worst issues really timely. And this data is actually, collected like a first collection, like primary thing. But then if you think about hospitalization, if you think about medication dispensation or something. Other data elements that would respond to the same phenomenon, Maybe it's more delayed, but maybe the SUS is now dispensing more psychiatric medications because there is an increase in psychotic disorders or something.
I don't think necessarily a control though. I think that's more like
It's like a parallel series,
yeah, it's
You're
more
measuring
like
the same thing, the same event, but in a separate system.
Yeah.
I think this is very interesting. However, I have 2 main concerns.
Mm.
First one is about the way we deal with mental health in our country, in Brazil. Sorry. So inside the logic of non-hospitalized care, you will, at least in Manaus, you will hardly ever see someone being admitted for psychiatric condition.
Okay.
They will probably be there if they go to an emergency hospital and have high hypertension, they will get a hypertension code, an infection code, but they will not get the
ICD.
Yeah, because we don't have structure to admit these patients, not even else. We don't have hospitals for this. So they're general hospitals. That's first one. And the second one is, even before the pandemic, our scenario for mental health care was already on the limit. So I'm wondering if after we have this breakpoint and things start to increase in terms of demand, where we're going to see this demand increasing, because we have no more health professionals, we have no more drugs to dispense. So maybe we wouldn't capture this, you see? I'm thinking of systems we have that have enormous lives, and I know this because I know I work there. So I know that people used to wait for 3 or 4 months for now they're waiting for a year. And this is to get a consultation.
Yeah, when I was curious, when I was saying that, I don't think it's a control because I don't think it's as sensitive. So you probably would see that effect lagged later.
Yeah.
And that's what I was going to suggest was the same suggestion, but with a different thinking about it, which in one of your arguments, you make the argument that EMS is a good, sensitive way to look what's going to happen in the public health, which I really like that argument. If you had that data of hospitalizations for one thing that is trackable, such as, for instance, alcohol disorder or suicides, and then you show that trend and you show that the hospitalizations bump up after, the EMS calls are rising, and then maybe some months later you're rising on the trend of hospitalizations, you might end up be able to show both the control but also the long-term impact. So when you can put this measure to say, if I look at calls, I can have a 1 month, 2 month lag to what's going to happen in the system. I wouldn't do it for this paper though, because I think there's a lot of rationale that needs to go into thinking about that. I think the point of having a control series is to make this second counterfactual to say, if I were to look at the time series of another unrelated thing, would I end up seeing the same behavior? So that's something to think about, but I don't think you necessarily need it. The only thing that I think you necessarily need is a sensitivity table when you compare different models to the data, and just show that are those different models showing a similar pattern, or is there a small important difference that could be attributed to the model you chose? But yeah, besides that, I think it's a great, fascinating paper and well done.
We are at time, folks, so I would invite everyone to share comments or questions of Eduardo online, if that's the case. But again, thank you for your presentation. Great work so far.
Yeah.
Really great pictures.
Yeah.
Really good to see.
It's very, very